She was 7 years old. She had gone to bed the night before perfectly fine. By morning, she wouldn't stop washing her hands. Her parents described her as a bright, social child. She loved school, played with friends, and had no history of anxiety or behavioral concerns. Then came the strep throat infection, the kind most children get and recover from within a week. She recovered, but something did not go back to the way it was before. Within days of finishing her antibiotics, her behavior changed in ways her parents struggled to explain. The hand washing became compulsive, sometimes dozens of times before she could move to another room. She developed fears she had never expressed before. She began having emotional outbursts that were completely unlike her. At night, she could not fall asleep without checking the door locks repeatedly. Her parents brought her to their pediatrician. The strep had cleared. Every standard test came back normal. The pediatrician referred them to a child psychiatrist. The diagnosis offered was early onset obsessive-compulsive disorder. Therapy was recommended. The family complied, but the symptoms did not stop. Over the following months, the pattern became harder to ignore. Each time their daughter developed a new throat infection or illness, her symptoms intensified. Her tics worsened. Her anxiety spiked. And then, after the illness resolved, she would slowly, partially, return to something resembling herself. Her mother kept a journal. She wrote down every sore throat, every new symptom, every appointment. The journal would eventually become the most important document in the room. The family saw 4 physicians across 2 years. They were told the same thing in different words. Children develop behavioral conditions. Therapy takes time. Give it time. She went home after every appointment carrying the same answers she had walked in with. And her parents sat across from each other at the kitchen table and tried to understand how a strep infection had changed their daughter. The question that stayed with them was not dramatic, it was quiet. If this was a psychiatric condition, why did it arrive overnight? Why did it get worse with every infection? And why did no one else seem to find that strange? Now here's where the medical records become unusual. In the late 1990s, a team of researchers at the National Institute of Mental Health began documenting a pattern they had observed across multiple pediatric cases. Children who had no prior psychiatric history were developing sudden, severe onset of OCD and tic disorders, almost always following streptococcal infections. The timing was not coincidental. It was the defining feature of the cases. The condition they identified was given a name: PANDAS, Pediatric Autoimmune Neuropsychiatric Disorders associated with Streptococcal Infections. The name is clinical. The mechanism is not simple. What researchers proposed was that in certain children, the immune system's response to strep infection produced antibodies that did not only target the bacteria, they targeted brain tissue as well. The region most affected, according to published research, is the basal ganglia, a structure deep in the brain involved in regulating movement, habit, and behavioral control. When those antibodies cross into the central nervous system and bind to basal ganglia tissue, they can disrupt the circuits that normally keep repetitive thoughts and movements in check. The OCD, the tics, the anxiety, they are not psychiatric conditions in isolation. According to researchers, they are the neurological result of an autoimmune process the child's own body triggered. Studies published in peer-reviewed journals, including work from the NIMH, documented that children meeting the PANDAS criteria showed symptom exacerbations that were temporally linked to streptococcal infections, meaning symptoms reliably worsened after confirmed strep exposure. Some case reports described children who deteriorated so rapidly that families brought them to emergency rooms, believing they were having a mental health crisis. What they were experiencing was a neurological immune response. The challenge for clinicians was that standard psychiatric evaluations do not test for this. A child presenting with sudden onset OCD in a pediatric or psychiatric clinic will typically receive a behavioral diagnosis. The connection to a recent strep infection requires a physician who knows to look for it. Research indicates that most general practitioners and even many pediatric neurologists were not trained in PANDAS criteria during the period when many of these children were first presenting. What researchers cannot yet fully explain is why only some children develop this autoimmune response to strep. Streptococcal infections are among the most common childhood illnesses worldwide. PANDAS remains rare. The genetic or immunological factors that make certain children vulnerable are still being studied. And then came a finding that changed how physicians understood this. Subsequent research expanded the framework. In 2012, a broader diagnostic category was introduced: PANS, Pediatric Acute Onset Neuropsychiatric Syndrome. This category recognized that the same neurological mechanism appeared to be triggered not only by strep, but by other infections, and, in some cases, immune system dysregulation without a confirmed infectious cause. PANS acknowledged what clinicians were increasingly observing in practice, that the brain's immune response could be triggered by more than one pathway. For families who had spent years being told their children had a psychiatric disorder, the PANDAS and PANS frameworks represented something important: not a cure, not a simple answer, but a documented, physiological explanation for what they had watched happen to their children. Treatment options, according to published clinical guidelines, include antibiotic therapy to eliminate active strep infection, anti-inflammatory medications, and in more severe cases, intravenous immunoglobulin or plasmapheresis, procedures that work by reducing or removing the circulating antibodies believed to be driving the neurological symptoms. Studies indicate that for many children, treating the underlying infection and reducing the immune response leads to significant symptom improvement. But outcomes vary. Some children respond quickly, others cycle through relapses for years. The diagnostic criteria for PANDAS remain a subject of ongoing discussion within the medical community. Not all clinicians accept the framework. Some researchers argue the evidence base requires larger controlled trials before PANDAS can be considered a definitive diagnostic category. Others point to the growing body of case reports and immunological studies as sufficient to justify clinical recognition. The debate itself has consequences. Children presenting with sudden psychiatric symptoms may or may not receive a strep workup, depending on which physician they see and what that physician has been trained to consider. What this case, and the hundreds documented alongside it, exposed was a gap in how medicine divides its categories. Psychiatry looks at behavior. Neurology looks at the brain. Immunology looks at the immune response. PANDAS sits at the intersection of all three, and for many years, the medical system did not have a clear place to put it. Parent-led advocacy organizations, including the PANDAS Network, have worked to increase physician awareness and push for standardized diagnostic criteria. Some hospital systems have established dedicated PANDAS clinics. The NIMH continues to fund research into the underlying immunological mechanisms. But families still report, in documented interviews and published accounts, spending years navigating a system that routes sudden onset behavioral change towards psychiatry before considering whether the immune system was involved. For the child in the case described at the beginning, whose mother kept the journal, whose every sore throat was followed by a worsening. The eventual PANDAS diagnosis came 3 years after her first symptoms appeared. She received antibiotic prophylaxis and a course of anti-inflammatory treatment. Her mother described the change as gradual, not a switch, not an overnight recovery, but over months, the compulsive behaviors lessened. The outbursts became less frequent. She began to sleep again. What medicine still cannot fully explain is why the autoimmune response begins, why it persists differently in different children, and whether there is a way to identify vulnerable children before their first triggering infection. That research is ongoing. She was 7 years old when it started. She had gone to bed the night before, perfectly fine. A strep infection came and went. And what came after, it took 3 years to have a name. For families who have watched a child change overnight, the question is not hypothetical. If your child's personality shifted in the days after an illness, and every psychiatric evaluation came back inconclusive, would you know what question to ask next? This video is based on real, publicly documented medical case reports and is intended for educational and storytelling purposes. It is not medical advice. If you or someone you know is experiencing similar symptoms, please consult a licensed physician. Medical mysteries, true cases every week.